3, 2, action.
Hello, and welcome to the College of American Pathologists media briefing. We're coming to you live from Chicago at the CAP 23 annual meeting. My name is Dr. Donald Karcher, and I'm the president of the College of American Pathologists. The CAP represents over 18,000 board-certified pathologists, the physicians who diagnose disease. Pathologists are at the forefront of disease because effective treatment starts with a correct diagnosis. The CAP also accredits over 8,000 clinical laboratories worldwide, assuring patients and the public that testing performed in a CAP-accredited clinical laboratory meets the highest standards possible. Before we begin, for members of the media who are joining us today, please submit any questions for our guests in the chat box during the briefing. If we don't get to your questions because of time, please be sure to follow up with the CAP Media Relations team, and we'll get those questions answered for you. I believe it's important to begin by discussing what continues to be a huge health concern, the many faces of COVID-19, along with RSV and the flu. We've gathered an esteemed panel of pathologists to update us on these infections as we head into the late fall and winter months. Joining me today are Doctors Leilani Valdez and Deanna Cardona. Please introduce yourselves. Let's start with Dr. Valdez.
Thank you, Dr. Karcher. I'm Leilani Valdez. I'm a community practice pathologist in a rural practice in South Texas, based out of Victoria, Texas. And in my job as medical director of the hospital laboratory, I serve my community to help make our patients healthier.
Dr. Cardona.
Thanks, Dr. Karcher. My name is Deanna Cardona. I'm a pathologist at Duke University. I serve the role of Associate Medical Director as well as Vice Chair and Director over Anatomic Pathology for the health system.
Great, thank you. So, pathologists are at the center of diagnosing disease, including infections such as COVID, RSV, the flu. These diseases may be off the front pages now, but we are saying, not so fast. They're very much still with us. So right now, the latest statistics from the CDC through the end of September shows that the test positivity rate, the percentage of tests in our laboratories that test positive, is currently 10.9%. That's down a bit, but still high. Hospitalizations are also down a bit, but still sitting high at about 18,000. Deaths from COVID-19 are still high and rising. We thought it would be useful to review the data and precautions our patients can take to keep themselves safe as we head into the late fall and winter months. So, Dr. Valdez, let's talk about test positivity. What does that mean? Is there a concern that it may get even higher as we move into the winter months and through the holiday period? And particularly, what are you seeing in your area?
During the summer, we actually saw a little bit of an increase, which was a little surprising because we were thinking that COVID might ease into that seasonal infection that we see, not unlike the flu and RSV. But we in our community saw an increase, as you mentioned, and it's on a little bit of a decline, but that it seems to be holding steady. And we worry that we're going to see an increase once we do get into that cold and flu season again. It's something we keep an eye on as a physician pathologist involved with the infection control team at my hospital. We do monitor how that positivity, that means out of all the COVID tests we're doing, what percentage of them are showing up as positive. And that gives us an idea of how much COVID is circulating in our community, because we want to be ready when it does increase for those patients to come in and be treated in our hospital. So it's important for our infection control team to have an idea what that number is in our community.
Yeah, great. Yeah, still with us very much.
Yes.
So the updated vaccine is now available. Dr. Cardona, why is it important to get this new vaccine?
Yeah, it's a great question. I think the easy answer is getting vaccinated is the easiest way to protect you and your loved ones, point blank. And I think we've learned over the years that the virus continues to mutate, and this new vaccine is going to help protect you better with those new variants. And so, again, I think it's if you want to protect you, protect your loved ones, especially if you lived with anyone that's elderly, immunocompromised, has chronic medical illness, getting vaccinated is the best way to protect them.
Yeah. So when's the best time to get the shot? And who should be getting it immediately, for
Yeah.
example?
So the new vaccine has been available for about 2 weeks now. And so anyone over the age of 5 is eligible to get it. As far as urgency, like who really needs it, I think it's those vulnerable populations again, right? Thinking about our elderly, thinking about immunocompromised, people with chronic medical conditions, or if you live with those individuals, I would really highly recommend that they get vaccinated.
Yeah, great. So, as we're constantly being asked about, COVID variants, it's always in the news. What's the importance of the different variants that are circulating out in the community? We know that viruses mutate. That's how they keep propagating and keep spreading. So how do those mutations make, the virus stronger or weaker? And, is there really a concern about these mutations and the strength or the weakness of the virus? Dr. Valdez, you want to start with that?
Sure, I'd love to. Well, viruses have one job. Their one job is to stay alive. And they can't stay alive without being in a host. And we are their host, right? So they have to do what they can to avoid being eliminated by their host, by our immune systems, by those antibodies we have to fight viruses, long enough so that we spread it to another host. So those mutations are kind of like evolution, right? We've evolved to make sure that we can live longer as humans. You can think of those mutations as a virus evolving to outwit the host, to escape our immune system. So it's important that we get vaccinated and allow our bodies to fight those new mutations that the virus is using to try and stay alive and move to the next host.
Yeah, great. It's good to put it into perspective in terms of we mutate too.
Yes, we do.
But viruses for sure, that's the only way they can stay ahead of the game. So the government is reinstating its policy to provide 4 free at-home COVID tests to each U.S. household. We've talked about at-home tests being another tool that people can use to minimize the spread of this virus. The gold standard, of course, is the PCR laboratory test. As pathologists, why is it crucial that people use these at-home tests correctly when taking them, when using them? Dr. Valdez, what are your thoughts on the at-home test?
Sure, that's a great question. As physician pathologists, we have teams of very well trained and educated medical technologists working in our laboratories to ensure that tests get done correctly and that the results can be trusted, right? At-home tests are wonderful, and they're wonderful ways for us to have people in our community identify the virus and stay home and take the precautions necessary to keep it from spreading. But you're not medical technologists with years of training, you're not pathologists, you're not physicians. So it's really important when you do these at-home tests that you really pay attention to the instructions. And even if you've done an at-home test for something else before, really look to make sure you're doing all the steps that the test asks you to do and you're doing it the right way so that you can have more trust and faith in that result from that test.
Yes. I can say as a pathologist with many years of experience, when I do an at-home test, I have to really think carefully about making sure that I'm doing every step possible, so every step correctly. So it's important and helpful advice. Dr. Cardona, these tests are different from the PCR tests that we conduct in our laboratory. Why is it important to monitor the expiration dates of at-home tests? People may have had at home for a while. And maybe you could also explain what's the difference between the PCR test and the at-home test, maybe before we talk about the expiration date.
So let's first address the differences. I think you'd mentioned, PCR tests, that's what we do in most of our hospitals, et cetera. And that really is looking at the genetic material of the virus. DNA, RNA, the acronyms that I'm sure a lot of people now are used to hearing about. And so it's really the most sensitive, meaning it is the most likely to detect the virus if you actually have the virus. The at-home test, it's great. It really is easy to use as far as accessibility, quick answers, but I think the most important thing is to understand its limitations. It's not as good as detecting the genetic material because it's looking for something different. It's looking for an antigen, which is, I'm sure people have seen the pictures of virus with the little things sticking out of the virus, right? Those are examples of what antigens could be, for example, that the kit is looking for. It's not as sensitive. So the risk is you might get a negative result when you actually still do have the virus. And so just understanding the limitations, if you know that you were exposed to somebody with COVID, right, and it was negative, I would be suspicious that maybe that's a false negative result. If you're still sick a couple days later or you're getting worse, I would say maybe that original result was negative. And I would recommend that if you have any suspicion that maybe you actually do have COVID and your home test was negative, to go into a clinic and go get a PCR test just to make sure.
Yeah, great. So, we probably all have some at-home tests in our closets at home that we've had for a while.
I know I do.
So I do too. So explain the importance of carefully looking at the expiration date.
Yeah.
That's usually listed on the box or somewhere that it has the expiration date of that test.
I kind of liken it to food. Food has expiration dates. Why do they have expiration date? Because it's probably not going to taste good afterwards, or it might be dangerous for you, right? So you throw it away. It's kind of similar to that. The test kits have reagents, have fluid, have things in there that will expire, which makes the test maybe not as accurate. Maybe you can't trust the results that come out of it. And so it's just one of those things that you take care, just like you would with food, to make sure that your kits aren't expired. Now, having said that, I know the FDA did publish a new list on their website in which they have extended some of the expiration dates for some of the kits. So if you do happen to have a kit at home that is expired, like I know I do, I would recommend going on the FDA website, seeing if maybe it's one of the ones where they have extended the date so that you can still use it. But if it's not one of those kits, I would either throw it away and or take very cautious, like when you use it, what results you actually get out of it.
Yeah, great. And now it's going to be available from the government, so
Right.
people
So
can
just get a new one.
replenish their supply. So let's talk about RSV and flu. Who is most affected by RSV? Dr. Cardona, can you speak to that?
Yeah. So I think most people are familiar with RSV because they think of like kids, right? Babies and infants, young children getting it. And they forget that there's actually a second population of people that actually are at risk of getting RSV. And that's our elderly and our patients with chronic medical conditions. And so it really is this kind of what we describe as a bimodal distribution, the really young and the really old that are at risk of getting RSV. And honestly, it could be life-threatening. It's really a serious illness that you should be careful about trying not to get.
Yeah, good. Thanks. So there are vaccines, thankfully, for now for RSV and also, as we've had for years, for flu. Dr. Valdez, can you get a flu vaccine and a COVID vaccine at the same time together?
Yes, you can. In fact, we in the Valdez household really rally every flu season in the past. I have my kids pretty well trained. They're in their young adults, teens ages, and they're not living at home. And around flu season, they always send me a POV, which is proof of vaccination, selfie with their Band-Aid so I can know and be proud that they're vaccinated. And my husband's even in on it because he just turned 60, so he qualified to get the RSV vaccine. And he went and he got his RSV and COVID and flu. And so he had a three Band-Aid POV picture that he sent me. And I unfortunately can't get the RSV, so I just turned 50. So I used that opportunity when I got my flu and COVID vaccine to get my first dose of my shingles vaccine. So in the Valdez household, we had multiple Band-Aids and multiple proofs of vaccinations.
Same thing the Karcher household, I can assure you. So is there any reason whatsoever to wait between shots? Is that ever necessary?
You know, it's not necessary. Some people don't feel comfortable having a couple jabs at a time, and so you can wait. For RSV, there are some different sort of guidelines around the vaccination. For example, if you are in your third trimester of pregnancy, you can get vaccinated between 32 and 36 weeks to protect your infant. And they will have those antibodies as long as you give birth 14 days after being vaccinated. That will be enough time for that infant to be protected entering their first RSV season, which is what we want to see to protect.
Yeah. So let's talk about the symptoms of these viruses. Dr. Cardona, many of the symptoms are similar, but some are different. How do you know whether you have COVID or the flu if you start having symptoms?
Yeah, so I agree. I think a lot of the symptoms are the same. You think about the fact that they're all respiratory viruses, and so they're going to present with runny nose, sore throat, cough, congestion, maybe some fatigue. I think that as the symptoms progress, though, and you really have perhaps difficulty breathing, like that would be a concerning feature. Maybe it's COVID, right? If you lose your sense of smell, your sense of taste, another sign that it could possibly be COVID as opposed to flu, RSV, or even just the common cold. So really, there is a lot of overlap, but there are some subtle differences that might help point you in the right direction.
Yeah, great. I mean, I think the bottom line is that we should not underestimate these viruses. They're dangerous, and we have things that we can do to protect ourselves and our families. So let's discuss some of those common sense things that, can help keep everyone safe, particularly as we're sort of approaching the holiday season. Hand washing, it's simple, but Dr. Valdez, how important is hand washing?
Simple, but sometimes the simplest things are the most effective things you can do to prevent spreading any kind of infection, actually. Right? We don't realize how many times a day we touch our face, right? We don't realize it. You say, oh, I don't touch my face. I don't touch my nose. You do. I promise it's unconscious. And what happens, you touch your face and then you touch other things, right? If you're not coughing into your shoulder, you touch door handles after that. And if you're not washing your hands, that virus has an opportunity, because all it wants to do is survive and stay alive and find a new host, has an opportunity to come behind someone who comes behind you, touch that door handle, then they touch their face, and that's it. Done. The virus has done its job. It's gotten to its new host. So the simplest thing of hand washing, to make sure before you touch surfaces, your hands are clean, the more we can prevent the spread to a new host.
Yeah. So masking, we know that's been controversial for a while. Dr. Cardona, what about masking? What should people think about when it comes to considering masking?
Yeah, so it's interesting. I had the opportunity to go to Japan. This is way before COVID. And one of the most striking things that I observed while I was there was just people randomly walking around with masks. And I thought that was just so odd. I mean, not used to seeing that here in the United States. And I asked, why are they doing that? And they're like, oh, they're doing that out of respect for you. Because they woke up that morning maybe with a runny nose, a slight cough, and they don't want to spread their germs to somebody else. That's all it is. It's just basic respect. And I feel that nobody here wants to intentionally get somebody else sick. Right? Like that, nobody wants that. And one of the easiest things you can do is, if you've got the sniffles, if you've got the cough, put on a mask, especially if you're around other people, especially if you're around someone that's elderly, immunocompromised. It's just some basic respect for your fellow man.
And it can also protect you, maybe on a more limited basis, but is also protection of you as, that the person that's actually wearing the mask. So it's important to stay home. If you are having those symptoms that you just mentioned, starting to feel sick, and you haven't had a chance to get tested, why is this so important? And particularly, for instance, if you know you're going to be indoors or maybe on an airplane, why is it important to, to sort of stay low, lay low, stay home, avoid those contacts?
If you have COVID?
If you have symptoms.
If you have symptoms,
but you haven't been tested yet.
Okay. Well, I think it's kind of what we've been describing, right? I mean, it's really trying to prevent the spread as much as possible. That's why testing is important, because if you know that you have it, I think your behavior will adjust. If you don't know you have it, but you're like, oh, maybe I do, maybe I don't, it's okay, I can go out in public. You're still threatening, literally threatening other people of potentially getting sick. And so I think it's just basic respect of trying to minimize spread.
Okay, great, thanks. Let's take a question from our members of the press, and can we scroll that question down a bit? I can't read it. Okay. Despite pandemic fatigue, why is it important to remain vigilant? You know, the population has gotten tired of hearing the word COVID. Why do we need to keep our guard up?
I'd like to start if that's
Please.
okay. So I mentioned that I participate as a physician leader on our infection control committee and in our efforts in our hospital. Prior to COVID, we were vigilant every time flu season rolled around, right? I remember early on when I started at the hospital, we had a 40-year-old, otherwise healthy marathon running female be admitted to our hospital and then unfortunately pass away just because she had the flu. It was complications from flu. And it was so striking to me that I said, let's figure out what the situation was here and if there's something that maybe we could have done differently. It turns out she wasn't vaccinated. And so from then on, I said, let's track our admissions to the hospital and see if vaccination status makes any difference. And for the next couple flu seasons, we didn't have any admissions to our hospital for vaccinated people.
Yeah.
I still track that data now. We get one or two, but usually those patients have comorbidities that make them more susceptible. And thank goodness we have not had any deaths. But we've been vigilant during flu season. Now we have RSV, we have a vaccine, so I'm interested to see if that helps us reduce the amount of patients in my community that are hospitalized during this season. And we've always had that vigilance for flu season, and we've treated it with great respect. And I think even past, post-pandemic, that vigilance remains. And we are all vigilant in the healthcare community because we know that it's part of our new reality.
Yeah.
And it's part of our job to keep our communities safer.
Dr. Cordone, you want to add anything to that?
Yeah, I think that, the term pandemic, it just gives everyone chills, really, like, oh, I don't want to hear that word anymore.
Yeah.
Flashbacks. And to your point, Leilani, I think that it's the new normal, so to speak, where we're used to flu every year. It was like flu season. Now it's flu season, RSV, we got to think about that. And now we just have to add COVID. And every year it's just being a little bit more vigilant, being thoughtful in what you're doing and how that potentially impacts yourself as well as others, and just being careful.
Yeah. Great. Well, look, thanks to both of you for being here today and providing this really valuable information. So please stay with us. Up next, we're going to be talking about the pathologist pipeline. Welcome back to the College of American Pathologists Media Briefing. As we all know, medical treatment can't begin until a diagnosis is made. Pathologists are the physicians who make those diagnoses. Recently, because of many factors, we're facing a growing pathologist shortage. So joining me today to discuss this critical issue is Dr. Kalisha Hill, Dr. Swati Bhardwaj, and Mr. Curtis Johnson. So can you please introduce yourselves, maybe starting with Dr. Hill?
My pleasure. Well, I am Dr. Kalisha Hill. I am a anatomic and clinical pathology practice owner. I have my own practice in rural Kankakee, Illinois. I'm also chief medical officer over 2 hospitals within my health system.
Great, thanks. Dr. Bhardwaj.
I'm Swati Bhardwaj. I'm a 4th-year anatomic and clinical pathology resident at Mount Sinai. I'm also the chief resident there and currently the chair of the Residents Forum of the CAP.
Great. Mr. Johnson.
Hi, I'm Curtis Johnson. I am currently a 3rd-year medical student at Michigan State University College of Osteopathic Medicine, and I got into pathology as a MedTech MLS.
Ah, great. So thanks again for all of you for being here. So first I'd like to have maybe each of us briefly share why we chose pathology as our medical specialty. So maybe Dr. Hill, we'll start with you.
Absolutely. When I was in medical school, we had a very robust histology course, and the chairman at the time, Dr. Ghosh, was hands-on with the medical students. We had specimens to look at, we had microscopes, slide boxes. We were very much educated to what a pathologist does. However, it wasn't until we actually had a patient in the OR that had a teratoma where Dr. Ghosh went in. There were literally news cameras, and when she got there, everyone waited with bated breath for them to find out what they had taken out of the abdomen of this man. And she looked at it, said, "It's a teratoma," and swished her hair and walked out. And I said, that was a boss lady moment, and I was so impressed with her and her knowledge and her skill. And then fast forward, when I was doing my gynae rotations, there was a surgeon that would bring the uteri down to the pathologist. And after a week, I stayed in pathology with the specimens rather than going up to the OR to close.
Yeah.
And those pathologists really inspired me today.
Great, great, thanks. Dr. Bhardwaj, how about you?
Well, my interest also started in med school. I got the opportunity to attend a tumor board during my med school. So tumor boards are these multidisciplinary meetings. You have a pathologist, you have a surgeon, you have oncologists, radiologists, and basically doctors from each and every specialty. And they were discussing cases about different cases and this particular patient, and everyone was clueless, what to do with this patient. The pathologist was the doctor who had the answer. What is the disease? And in my mind, that room, that scene was like being led by the pathologist like a general of the army who knew who is the enemy, who knew what's the weakness of this enemy. In this case, the cancer, the disease. The pathologist knew that's the receptor, that's the drug you should use. I wanted to be that doctor who's guiding everyone's decision. That's why I chose pathology.
Great, great. So I know, Mr. Johnson, you're a little earlier in your career. What about you? What made you decide pathology is for you?
So I actually decided on medicine very late in my academic journey, but pathology very early, which is good. I was medical lab scientist at a community hospital down in Toledo, Ohio, and one of my mentors there really just kind of got a bug in my ear. He's like, you should go to med school. You should become a pathologist. And honestly, I haven't looked back yet. It's been by far my favorite subject to learn so far. I get to go to these meetings and do things like this, and I really wouldn't change it for the world.
Yeah, great. So in my case, I went to medical school to be an internist, internal medicine doctor. And the pathology course was by far my favorite course in medical school. I mean, nothing came close, but I had my target was being an internist. So I did a year of internal medicine residency. And then during that year, I realized what I loved about internal medicine was the diagnostic challenge, getting a new patient, figuring out what's wrong with this patient. And it reminded me of why I loved pathology in medical school so much. That's what pathologists do. We get to the bottom of what's really wrong with the patient. We are sort of disease detectives in a way. And I decided I want to devote my full time to that. And so after that first year of medicine training, I went internal medicine training. I went straight into pathology, and I've never looked back. And I've been in practice for 45 years, and I still get as excited today as I did back then, solving the puzzle of what's wrong with the patient. So thanks for sharing your stories. So Dr. Hill, let's discuss some of the reasons why we're facing a pathologist shortage, and why is this so important?
Yes, and that's a very timely question. So coming out of the pandemic, we lost several of our colleagues. Some of them retired, some of them changed their work practice, some of them went part-time, some of them left medicine altogether. So that was the immediate impact. But we also noted that there are barriers to having people choose pathology or medicine in general as a specialty. We need more ACGME spots so that we have more residency slots for our medical students to apply to, give them a variety across the country. So that's another opportunity that we have. And I would say one that we are actively addressing with the CAP is the J-1 visa issue. We have many qualified people that are interested in pathology residency, and having them come here to train sometimes is a barrier. And so we want to work through that to make sure people have opportunities so that we can attract the best and the brightest from our country and from around the world to practice medicine here.
So once those international graduates train, if they don't get a waiver of their J-1 visa requirements, they have to go back, not able to stay in the United States in practice.
That is correct.
So that's a real loss.
Absolutely.
So Dr. Bardwaj, what was your experience, when you were applying to residency programs, in terms of the number of available resident positions that you saw and the residency programs that you were looking at?
So I applied for residency back in the year 2020. That time there were about 800-ish applicants from within the US for 600 spots, in nearly 600 spots that year. But there are many more applicants from outside, as we were discussing, people who come in on visa. So I feel like even at that time I felt that there could be more positions. There was 2 or 3 applicants for every one single position available. So even though most of us got into, but it was slightly competitive, and we, like Dr. Hill said, there could be a benefit with more spots for pathology.
Yeah, great. So there's so many subspecialties within our specialty of pathology. Most of the public is familiar with forensic pathologists. It's on television all the time, what a medical examiner does. But there's also surgical pathology, which is diagnosing disease in biopsies or tissue that's removed at surgery in the OR, as Dr. Hill related earlier. Neuropathology, maybe that's that subspecialty, diagnosing disease of the nervous system. Dermatopathology, diagnosing skin diseases, including skin cancer. I personally have been practicing for 45 years, as I mentioned, and I'm a hematopathologist. That involves diagnosing diseases of the blood. The list goes on and on. We have many, many subspecialties. What kind of person do you think should be drawn to pathology? Can you all give me maybe your thoughts on this? And Mr. Johnson, why don't you start?
Sure. So I think in order to understand and appreciate pathology, you have to really be detail-oriented and understand that it really is the basis of human disease. That's what we're studying, and that's what we're diagnosing. So you kind of have to have an innate curiosity and an eye for the details.
Okay, Dr. Bardwaj, what do you think?
I'd agree with Mr. Johnson. You need to be curious. You need to have an eye for details. But I also feel that pathologists need to be good communicators. We need to be good at teaching, because we are educating residents, trainees, but also our co-clinicians in other specialties who are always looking for answers, and we are the ones giving them. We are also educating our patients. So I feel like good communication skills is also a big requirement.
Yeah, great. Dr. Hill.
Yes. I would say the greatest characteristic that I've noted in any pathologist is exactly what you stated. We are very curious, and it reminds me of a childhood cartoon, Inspector Gadget, because that particular character was constantly investigating things and using technology. So you fast forward to what we do today. We use many tools in pathology to diagnose cancer, and that curious nature and the desire to solve is what really drives pathologists to do what they do. And it really benefits our patients as being the doctor's doctor as well as the patient's doctor.
Great. Yep. So, Dr. Hill, we'll stay with you. What is the CAP doing to bend the curve when it comes to attracting more medical students into the profession?
Absolutely. So right now we have a wonderful pipeline initiative, and that has already generated us nearly 200 pathology pipeline champions. And so these physicians, medical students even, are communicating with the younger generation and attracting them into medicine and ultimately into pathology. So that effort really has been a groundswell that's moving forward very quickly, and it really is offering the opportunity for more people to know what pathologists actually do. And so that has been our other barrier, just making sure that the general public is aware. We had a nice boost during COVID for the public knowing what laboratory medicine was about, but we have to use that to continually launch the value that pathologists provide to patients. So that work will continue and grow.
Great. Sounds great. Dr. Bardwaj, pardon me. What's the role of residents in the CAP? You know, how important is the position of a resident member of the CAP?
It is extremely valuable and important, and I'm so grateful to CAP and the entire leadership that residents are valued. CAP is the hub and the platform where residents learn. There are so many learning opportunities, and also are given a voice, a say in decisions. So just I'm representing residents in the Residents Forum. I know that there is a seat for Residents Forum chair at the Board of Governors. That says a lot, that the residents' voice is heard in every important decision. And I think that value that CAP gives to the residents is unparalleled.
Great, great. So, Mr. Johnson, the CAP now involves medical students more than ever. What have you learned, being involved in being part of the CAP?
I think the biggest thing that I've learned is, this is something that Dr. Hill talks about a lot, is advocacy. Really standing up for the profession and also educating the public. And I think the pandemic, like you mentioned, offered a great opportunity for that, but we still have a lot of work to do. So the thing I try and take away from, being involved with the CAP is how can I, as a medical student, bring that back to my institution and really enrich others' education moving forward.
Great, great. So let's take some questions from our members of the press. So the first question is, what are some of the ways that technology is changing the field of pathology, and do you think that is having an impact on the pathologist shortage, either now or in the foreseeable future?
Yes, so that's a very timely question. We are already seeing AI being used in some subspecialties. Radiology is a good example. The radiologists in my hospital just onboarded their software literally 2 months ago. And so we are anticipating that AI will be utilized in pathology in the near future. And there's always that initial area where it's utilized, and then it takes some time to get out into other areas, but definitely see that in the future. But we have to recognize that we have already been using and owning technology. We use the statistical analysis, for example, for estrogen receptor staining. We use a computer to detect the percentage. And so we're already using technology and computer thought process software in our day-to-day life, and it's only going to expand. But the key point is that any specialty, including pathology, we embrace AI, we own it, and we bill for it so that we can make sure we're offering the latest technology to our patients, as well as can support continuing these services to our community.
Yeah, and I think that's a great point, and particularly about AI. And I would just say from my own experience, there's maybe a false impression that somehow AI is going to mean that we need fewer pathologists. We are learning very quickly that AI only works when we have the pathologist overseeing it, interacting with that computer, and ultimately AI is going to allow us to make better, deeper, more actionable diagnoses, not just faster diagnoses. It's just not going to work out that way.
As Dr. Sanjay Gupta said yesterday, we can use AI, but we have to trust and verify. And so if you have to verify, that actually may take you longer. So it may not make us more efficient, but it will definitely help us with our patients.
Yeah, great. So here's another question. How can we ensure that pathology remains an innovative field moving into the future? So Dr. Bardwaj, you want to start with that one?
Well, I think what we're already doing is embracing new technologies. So if we are going to remain innovative when we are open to change. And we as a specialty are open to embracing technologies. And you're giving a platform to younger residents. You are giving a platform to more curious minds in a way. I think if we continue to do that, we will continue to remain an innovative specialty.
Yeah.
There are awards for new innovations. You encourage innovation. So I think CAP does a great job of doing that.
Yeah, great. So, Mr. Johnson, what's your take on, staying innovative? You're in the very early stages of your career. How do you view that sort of looking over the horizon?
Yeah, pathology has been around for a long time, but it's also a very rapidly changing field, as you mentioned, with technology. I think the biggest thing that I see moving forward is, bioinformatics, big data, and we kind of have a lot of power in that regard to be able to provide information to healthcare systems, to industry, you name it. So I think that is something that we can really lean into and embrace moving forward.
Okay, very good. Well, look, thanks very much for sharing your stories and your perspectives with us today. So those of you members of the press, please stay right where you are. Coming up, we're going to have a frank discussion about eliminating health disparities in the transgender community. Welcome back. The CAP is committed to erasing health disparities in medicine, especially when it comes to the laboratory testing. We'd like to discuss making sure that testing is comprehensive and accurate for the transgender community. Joining us today, virtually, are Doctors Margaret Compton and Kim Ely, who are joining us from Nashville, and Dr. Angela Lapis, who practices in Texas. We also have a very special guest, Ms. Shanine Lynn Parker, who is CEO of Brave Space Alliance here in Chicago. So welcome to all of you. Doctors Compton and Ely, please introduce yourselves to our audience.
Hello, my name is Margaret Compton. I'm a cytopathologist at Vanderbilt University Medical Center in Nashville, Tennessee.
Great.
Hello, and I'm Dr. Kim. I'm Dr. Kim Ely. I'm a cytopathologist at Vanderbilt as well. I'm the medical director of the cytopathology department and the director of the cytopathology fellowship program.
Great. And Dr. Ely, I apologize for slightly mispronouncing your name.
That's quite all right.
So, Dr. Lapis, please introduce yourself.
Hi, my name is Angela Lapis. My pronouns are she, her. I am a private practice pathologist down here in Victoria, Texas, which is South Texas. And I guess is a common theme, I'm also a cytopathologist. I serve as the section head in our department, and then I also serve as a medical director of some of our various laboratories.
Great, thank you. So, Ms. Parker, please tell us a little bit about yourself and the Brave Space Alliance.
Absolutely. Well, hello, I'm Shannon Lynn Parker. She, her pronouns. I am the Chief Executive Officer of Brave Space Alliance. Brave Space Alliance is a Black-led TGLBQ social service organization that centers the lives of the most marginalized through essential needs sources, right? So we're talking about access, access to food, access to housing, access to clothing, access to health care, and in its most unfortunate incidents, access to a dignified burial. So those are our 5 pillars of dignity, and I'd love to talk more about those things as we progress.
Great, thanks very much for joining us. So, Drs. Compton and Ely, as pathologists, how did you first become aware of health disparities that face the transgender community, particularly in medical testing, which is our area?
Yes. Well, we first became aware for the role of pathology in LGBT plus health through a pap smear from a transgender man. The requisition that accompanied that pap listed the patient's female birth name rather than his preferred name and recorded him as female. And so that was very misleading to us. When we reviewed the pap smear at the time, we thought that the changes were that of an ASK-H, which is an atypical squamous cell, high grade, cannot be excluded. So that's kind of like a lesion that looks like a moderate or severe dysplasia. And typically these are followed or managed with colposcopy and biopsy, which this patient then underwent. And the resultant biopsy was negative. The patient then came back about a year later, and the requisition again listed the patient as a female. And we looked at the pap, and again, the changes looked like an ASK-H lesion. So in light of that prior negative biopsy, we kind of scratched our heads and we did a deeper dive into the electronic medical record, at which time I think Margaret, my fellow at the time, ascertained that the patient was indeed a transgender man who was receiving gender-affirming hormone therapy. So this prompted us to do some reading on androgens and the effect on pap smears, and they can in fact produce changes of atrophy. And we didn't really think about atrophy at the time because the patient was young. And typically we see atrophy in postmenopausal women. And these atrophic changes can in fact mimic those of ASK-H and even a high-grade lesion. So we were able to correctly and appropriately then diagnose the patient as having atrophy. But unfortunately, the patient had to undergo an unnecessary colposcopy and biopsy, and no doubt experience a lot of anxiety with those procedures.
Yeah, great. Other examples? Can you give us some other examples of important things pathologists need to know before they evaluate a transgender patient, particularly a patient's test results?
So one thing that I think is important to know about is that certain laboratory tests can have sex-specific reference ranges. So a reference range is the values of the test where we're saying this is normal for most individuals. And certain tests such as hematocrit and hemoglobin can be affected by hormones such as testosterone. Another example would be high sensitivity troponin, which is used to detect heart attacks, has sex-specific reference ranges, and it's somewhat unclear as to how exogenous hormones and the duration of exogenous hormones would affect somebody's troponin values. So it's very important to understand what hormones someone may be taking, as well as somebody's natal or birth sex can be important in getting an accurate understanding of their laboratory test results.
Yeah, great. Obviously, things could be missed if the pathologist isn't aware that their patient is transgender, first of all, and then whether or not there's that person has undergone any physical transition or gender-affirming therapy. Are there other examples that you wanted to raise?
So I think one thing that we've found in our practice is often the patient's gender is not correctly recorded in the electronic medical record. One study found that over half of patients had a disparity in their gender that they identified as well as the gender that was listed in their medical record. And not only their medical record, but also the laboratory information system, which is the interface that those test results go into and compare against value, the normal reference range values. We also had one individual approach us at the College of American Pathologists meeting, and she expressed that her daughter is transgender, and while she was allowed to be able to change her daughter's name and gender identity in the medical record, the patient portal still showed the incorrect gender and the patient's original birth name. And she was not able to get this fixed, even by talking to the medical center or by talking to the company who produced the patient portal itself.
Yeah, that's a very important example. And let me just say, I have a transgender grandson. And so this whole issue is very personal to me. So, Dr. Lapis, as a member of the transgender community and a practicing pathologist, can you talk a little bit about what you've experienced both as a physician and as a patient when it comes to getting the right care and the right testing?
Absolutely, thank you. What I've seen, from the patient or from the physician perspective, is that despite increasing research centered on transgender healthcare needs, there seems to still be a knowledge gap, a generalized knowledge gap among physicians. One, knowing that this research is even being done, and two, that this research is being published in peer-reviewed high-level medical journals, and is even being filtered into society-level publications such as CAP Today. I was recently at the CAP annual meeting, and I was able to take part of the residents forum and speak with residents afterwards. And one thing that I really understood and that became clear to me from the questions I was being asked is that these residents want this information. They understand how this information is critical for them to provide optimal patient care for their patients. And so in that sense, I think it's incumbent on us that we put this information out there in a very fundamental way, that this information starts getting disseminated formally into the medical school curricula, and that it gets further refined and expanded during their residency experience.
Go ahead, please.
Oh, and I was going to say, so, and as a patient who is, part of the transgender community, one thing I've really seen is it's really coming down to an access issue. Access to culturally competent and sensitive physicians, access to health insurance, access to health insurance that'll actually even cover these tests. access to appropriate ICD coding on the test, access to accurate SOGI data. And I can say from my personal experience, I understand what it was like to have health insurance companies refuse to cover some of these very important tests that I needed as I was undergoing my gender-affirming hormone therapy. And so I was in a position that I could, essentially help mitigate some of that personal cost. But that is an incredible access issue for so many of us within the community. This insurance, issue and lack of coverage, and then just also general cultural sensitivity and competency within the healthcare industry to make the healthcare industry and the healthcare setting itself inviting so that we know as patients that they want us to be there and that they will do the very best that they can to give us the best care that we need.
Yeah, great. And obviously, I think you mentioned all the different points in the healthcare system where we need better education and better recognition of the transgender community and that community's needs. But you really raised an important point about educating the next generation of physicians to be more knowledgeable and more sensitive on these issues. So I feel it's important, even though a transgender person hasn't started a physical transition, it's still important to know biologically what sex they have at birth and why. Dr. Lapis, can you just elaborate a little bit more on that?
Yes, thank you. I think one of the main crux of that is that regardless of where somebody is along their gender transition, regardless of where they sit in that process, I think it's really important that when we are considering cancer prevention screening guidelines and other preventative healthcare measures, that we have an understanding of the patient's current anatomy. And when we talk about that, what's generally being termed now is the idea of the organ anatomy or the organ inventory or the anatomic inventory. And essentially what that is, that really shouldn't be seen as a new concept. It's really just good medical record taking. Essentially what we're asking is, as physicians, we want to be informed of what organs a patient might still have in order for us to understand how these might affect laboratory values or other possible pathologies that we might experience as we're evaluating the patient. And
Great.
These organ inventories, they're really just almost like these check sheets, almost like whenever you go into a doctor's office and you'll have that check sheet that says, please check if you've ever had asthma, bronchitis, heart disease, kidney disease. Essentially, the anatomic inventory is the same type of sheet, and it just lists out what an individual patient may or may not have. And I think that really informs us within our medical understanding of what to look for and how best to provide care for these patients.
Yeah, and that anatomic inventory, I haven't seen it yet as a patient, so I think we still have a ways to go to make sure that that's there for every person. Drs. Compton and Ely, there seems to be a communications concern when it comes to primary care physicians knowing how to best serve their transgender patients. This can be traumatic for the patient, and if we don't engage a patient in this important conversation, they may not get important tests that they need to stay healthy. Can you both speak to that point?
So I would echo what Dr. Lapis had said, that education of the next generation of physicians is incredibly important. This is 10% of our patient population falls into the LGBT plus community. And so we need to be educating medical students as to how to best serve these patients. And in addition, many specialty societies provide continuing medical education on this topic for physicians who already are in practice. So education is a huge component, and I think Dr. Ely was going to speak a little bit to the organ inventory.
Yes, I was going to talk a bit about the organ inventory as
please
well.
do.
And yes, and how important it is to know what organs have been removed and what organs remain as the patient goes through the transitioning process. Not only is that important for the workup of a potential malignancy should it arise down the line, but it also dictates appropriate cancer screening for those organs that remain. Most trans men undergo gender affirming surgeries more commonly than transgender women. Typically, mastectomy is the most common, followed by hysterectomy with or without the removal of ovaries, and then finally, gender reassignment surgery. And while we don't have specific guidelines in place for transgender individuals, we're applying those that we have for cisgender individuals. And then I'd also like to mention, there is an importance of having that information of sex assigned at birth, natal birth, or because that is going to drive clinical reminders for screening tests like pap smears and prostate exams. So that is really important. And then as Dr. Compton had, some of that is used in the calculation of the glomerular filtration rate, and that is also contributes to calculating appropriate medication dosages. So we need all of that information. And, people need to, clinicians, the community, know their definitions, know their terms, and what, sex means, what gender means, gender expression, and all of these terms need to be at our fingertips. As we evaluate these patients. Yes.
Yeah,
So
great.
I think
Go ahead.
we talk a lot about personalized medicine. And when we think about personalized medicine, we're thinking about really fancy, testing genes and finding targeted therapies for cancer. But this is another form of personalized medicine where we're really meeting the needs of the individual. We're seeing, okay, you're a man, but do you still have a cervix? Have you undergone hysterectomy, or do you still require cervical cancer screening? And I also think it's important, it's contingent upon the physician to be able to communicate to the patient why they're asking certain questions. Patients may be uncomfortable to disclose some of this information out of fear of discrimination. One study found that 15% of BIPOC transgender individuals experienced rough or physically abusive treatment by their physicians. I just want to let that sink in, that 15% felt that they were physically mistreated at their doctor's office. So being able to communicate to the patient why knowing that they are transgender, why knowing sex assigned at birth is important for not only those cancer screenings, but sometimes a complaint that may seem completely unrelated to their sex, such as they're coming in with chest pain and you're drawing a troponin level, and you need to know that information to be able to accurately interpret the troponin. So it's really contingent upon the physician to be able to communicate that to their patient.
Yeah, those communication skills really important. Dr. Lapis, any additional thoughts on this?
No, I completely agree with what's already been said. And I think what we're talking about here is this idea of cultural sensitivity, in which, as a transgender patient, what we're looking for is that, as has been said, our physicians, address us with the proper pronouns, make the healthcare environment, an inclusive and inviting area for us to come to. And beyond that, also understanding just the scientific level competency, which is really important within the transgender community, which has been already alluded to in terms of knowing what tests to order, what laboratory reference values are necessary. And I think one issue that, as we kind of contemplate this idea of a lack of cultural sensitivity, that it does really become a barrier to just generalized access of healthcare. Because when I was starting my transition and when I was, visiting with our peer support groups, there was this underlying thread of some of my friends who would talk about, how they were mistreated at certain offices and how they would never go back to that office. And essentially what that meant was that they were no longer going to be receiving any particular medical care at all. And so as we can, amplify this issue of transgender healthcare, we also have to understand this generalized effect of how, if we have these barriers to access, not only to transgender healthcare, but for these individuals, they have a barrier to access for any healthcare. Yeah. And I think that as the physician community, that is something that we really have to think about, in terms of how we are dealing with, in a hopefully sensitive way, our patient community.
Yeah, that's great. Great points for sure. So, Ms. Parker, let's turn to you. In your work at the Brave Space Alliance, what have you seen when it comes to the Black transgender community, particularly getting correct medical care?
That is a wonderful question. So I've seen quite a few things. You know, speaking for myself, having transitioned at a very young age, I am now 30 years on HRT. So I've seen best practices come and go, if we will. So thinking about what I've seen in terms of health disparities amongst Black transgender individuals, one, we've taken transgender issues as from more of a public health lens, but not necessarily from a medical lens, which has done some great things on one hand, but in another thing have left some things to be desired. So in terms of Black trans people, we've seen an overemphasis on HIV/AIDS prevention, which is wonderful. We've seen a lot of the lens focused on STI, STDs, but we don't see a lot of whole patient perspective, right? When we think about the health disparities of Black people, period, by and large, we see overrepresentation of hypertension. We see cancer, right? And we oftentimes forget, well, Black trans people are still Black people who still face these things. So if we're talking about Black trans folks who are more than likely to experience poverty in their lifetime, more than likely to be underinsured or uninsured, will have less access to testing in various areas, well, we will see a virally suppressed community in terms of HIV/AIDS, but we will not see a community of individuals who actually are treated or even aware of high blood pressure. Yeah. We'll see individuals who have no access to cardiology, things like that. So what I'm seeing more and more is a gap filled in one space, but a gap that is left unfilled. I just had a friend recently, a Black trans woman who had a stroke. But again, her blood pressure was through the roof. But everyone's focused on her viral suppression, which is really easy to manage at this point. But we're leaving so many other things left out of the conversation.
The whole person, in other words.
The whole person, yes.
Yeah.
So that's what I'm seeing amongst Black trans people, is there is a lack of whole person care because the approach is very public health centered, which again is wonderful, but it's not very medical centered.
Yeah, great.
Yeah.
Thank you. There's another part of the community that represents the I in LGBTQIA, intersex individuals, those who are born with both male and female genitalia. Sometimes these intersex traits can involve internal organs and hormone production and may not be apparent until puberty or maybe never at all. How do we take care of them?
I think that's a great question, right? So again, because so many gender variant folks are, again, looked at through the lens of public health, we oftentimes don't have conversations around individuals who have those mosaic chromosomal patterns or ambiguous genitalia, right? So oftentimes, those are individuals who we don't have access to. You know, they're just kind of left in this very gray area where they're largely untreated or unrecognized. So I believe that that is a community that we need to do a lot more outreach to. We need to have a great deal of knowledge expansion on, and we need to be very intentional about engaging that population.
Great, great. Any thoughts, Drs. Compton, Ailey, or Lapis on this issue, intersex?
Sure. So I'd just like to say that the intersex community, it's a broad umbrella term that really covers a wide variety of different people. Intersex is fairly common. It's between 1% to 2% of the population in the United States, which is approximately the same number as the number of people with red hair. But we have had, as you mentioned, there may be a variety of different presentations where some individuals may not ever be aware that they're, for example, of a chromosomal difference until an infertility workup or may never be aware of this, whereas others may present at birth with, for example, ambiguous genitalia. And I think one thing that we've seen in the medical community is that there has been unnecessarily medicalization of the intersex community. So the majority of these conditions don't require any type of medical treatment at all. Now, there are certain conditions that will need some hormone therapy or assistance with electrolyte balance as infants, but for the majority of people, there really is no need for medical treatment. And I think it's the medical community putting their idea of what male and female bodies should be on infants that really cannot consent to any type of medical treatment. So Lambda Legal has actually put out a document about the ethical treatment of intersex people and how hospitals should work with these individuals optimally. So I think it's important to that hospitals and medical personnel need to recognize, first of all, their own biases, and then normalize that these conditions are very common in our population.
Yes, thanks. So let me just sort of turn to this question for all of you. What do you all want people to know, especially in the medical community, about the importance of making sure all patients get the best care possible? Can you all, maybe Ms. Parker, can you start with that, and we'll let everyone weigh in on this?
Sure. So I think first and foremost, thinking about the historical ramifications of the one-size-fits-all approach, recognizing that every individual that's in front of you is a unique whole individual who requires very specific care. Yes, we absolutely have to be sensitive to the individual that's sitting in front of us with respect and fidelity of the natal condition in order to get the most optimal results. I think that those things are so important. Again, as I said, when you asked me the first question, increasing access to medical care in general for transgender people is so important. Creating a warm, welcoming environment where the individual can be approached as a whole individual and receive whole person care, I think is another thing. And also to medical communities really being very intentional about doing a deep dive in what transgender needs are. One thing I left out is a lot of trans women, particularly Black trans women, have engaged in injectable silicone practices, Those are things that we don't think about, right? We do not think about those things, the effects of an individual having injectable silicone for over 10, 20, 30 years even.
Yeah.
What does that look like? What does that future lead in, especially talking about pathology? So I'll kind of just stop there and pivot to the rest of the folks.
That's great. So let's start with Dr. Lapis, and then we'll get to Drs. Ely and Compton. Dr. Lapis, what do you want people to take away from this?
I would really say just very quickly, in terms of our role as a physician, that was our oath. That was the oath that we took to provide the best possible patient care, to do right by our patients. We took that oath the moment we turned from a graduating medical student to a first-year physician. And I don't recall there ever being any exclusions into that oath that would allow us to give substandard medical care intentionally to any patient, or that would allow us to think that by omission we should not do the very best we can by our patient.
Yeah.
So I would really just crystallize it with that we took an oath to do right by our patient.
Great reminder that we all took that oath. Dr. Ely?
Yes, I would echo the comments that have been made, especially the importance of not addressing these patients kind of in a one-size-fits-all manner. And then I'd like to bring up the topic of faulty assumptions, and that clinicians and even non-clinicians can make faulty assumptions about this community, and in that manner can really impede the appropriate health care of this community. And one way is that some clinicians assume that a transgender man is not engaging in penile vaginal intercourse, and as such is not at risk for cervical neoplasia, and therefore does not need cervical cancer screening. So they are not giving the patient the opportunity to speak up for themselves and to engage in that conversation about what their sexual practices are, which would allow them to have the best cancer screening. So sometimes these topics are sensitive, sometimes they're uncomfortable, but they need to be addressed.
Yeah.
And we just have to really pump the brakes when we are making an assumption about these individuals. And then another example, and I'll allow other people to speak, is that, you know, it is uncomfortable for trans men to go to an OBGYN and have a pap smear, have that inspection. And in some studies, like up to 90% prefer another method for a screening of their cervix. But there still does remain individuals, transgender individuals who have anxiety with the fact that their cervix is not being examined by a healthcare professional. So that's the importance of engaging with these individuals and asking them what they want. What type of healthcare screening do they want? What do they feel comfortable with? What don't they feel comfortable with? And just modifying our practices to meet their needs.
Great. Dr. Compton, takeaways from people on this?
Oh my goodness. Well, there's been so many amazing points raised already. I mean, this is our sacred duty as physicians to make sure that we are providing appropriate, personalized care of the whole person. Transgender people get thyroid nodules, get knee pain, get hypertension, get other medical conditions. So treating the whole person, providing the best health care possible is so important.
Yeah, great. Yeah, the whole person. I think that's a real takeaway for me, for sure. So let's take a question from our audience. What role does HPV testing play in the health care of transgender and LGBTQIA individuals? So HPV, who would like to start with that?
Well, I can speak for that. We don't, there's
Please.
a lot that we don't know about the prevalence of HPV in transgender men and transgender women, and there's a need for research. There's a need for large cohort research. There does appear to be a role for HPV in trans women who have undergone vaginoplasty via penile skin inversion. The other technique is intestinal transplants, and usually the malignancies that arise in that context are adenocarcinomas, and there's no association that we know of between adenocarcinomas and HPV. So that much we know. We don't know about the HPV status of the donor sites. So the skin that's taken from the genital sites from men has a rather high prevalence of HPV, like around 25%, depending upon where. That has not been studied. We just don't know. There's the idea of HPV self-collection, which I think would be a great approach for gender minorities, because this would alleviate some of the physical and emotional barriers that they confront during PAP acquisition. So I think we're going to begin to see more of that. Right now, self-collection for cervical cytology is not yet FDA approved.
HPV is the virus that causes progression of cervical dysplasia and can lead to cervical cancer. It can also lead to dysplasia and cancer at other genital sites, including penile skin, vaginoplasty specimens, as well as anal cancer. And it is as yet unclear what the benefits would be and what the appropriate screening guidelines would be for transgender women. There is some evidence that transgender women may have persistent HPV infection in neovaginas. However, it's unclear if screening would help prevent cancers, and if so, what the optimal screening method would be. So I think there's a lot of research yet to be done.
So it sounds like, in a way, to summarize HPV, is we have a lot still to learn, about how to apply HPV screening and treatments, et cetera, for HPV. So unfortunately, we're out of time for this segment, but I want to thank all of you very much for a great discussion and bringing out some great points. So please don't go away. A discussion about fertility clinic laboratories is next up.
This one.
Yay!
Thank you so much. I don't think so.
Welcome back to the College of American Pathologists Media Briefing. We are broadcasting live from Chicago at the CAP annual meeting, and I'm Dr. Donald Karcher, president of the CAP. Fertility clinics are garnering their share of the recent headlines. The rise in reproductive medicine may have several reasons, possibly due to younger couples or individuals delaying the starting their families, choosing rather to concentrate on their career, or maybe saving to start a family. Whatever the reason, handing over the future of your family is an important and serious decision. In 1993, the CAP began an accreditation program to assist laboratories in fertility clinics. We began working with SART, the Society for Reproductive Technology, and ASRM, the American Society of Reproductive Medicine, to make laboratory procedures better and safer. Joining me for this important discussion is Dr. Richard Scanlon and Ms. Denise Driscoll. So thanks for joining us. Sure. Can you both just spend a moment to introduce yourselves? Dr. Scanlon, you want to start first?
My name is Mick Scanlon, and I've been a pathologist for almost 40 years. I work in Portland, Oregon at the University Hospital, and I also am heavily involved for several decades with the laboratory accreditation program of the CAP, and I'm currently the chair of the Council on Accreditation.
Thank you. Ms. Driscoll?
Yes, hi, Denise Driscoll, and I am the Senior Director for Accreditation and Regulatory Affairs at the CAP. I've been with the CAP for a couple of decades, and love working with laboratories to make them safe for patients with accurate and reliable test results.
Great, great. So thanks again for both of you being here. Dr. Scanlon, let's start with an explanation of laboratory accreditation and regulation and the differences between the two.
This is a difficult thing to explain, but I'll do my best. So in 1988, the Congress decided that all clinical laboratory testing would come under regulation by the federal government. The federal government wrote regulations that would say what clinical laboratories need to do. There were so many laboratories, however, that the government didn't have enough capacity to inspect all of the laboratories, so they created something called accrediting organizations who were given the right to establish that labs are in compliance. When a lab is inspected by an organization like the CAP, they are getting accreditation. Accreditation is voluntary. You can do it instead of having a regulatory inspection by the government.
Great, great. Thanks for clearing that up. So, Ms. Driscoll, does the government regulate fertility clinic laboratories like they do other clinical laboratories? Is it the same or a little different?
It is a little different. CMS does accredit or inspect the regulatory aspects for chemistry and andrology, but they don't get into the embryology parts and the banking of embryos. So it is different. So they have a partial responsibility, but CAP takes on the entire operation of a reproductive laboratory.
Great, great. Thank you. So let's talk a little bit about what part of the fertility clinic can actually be accredited.
We accredit the entire infertility laboratory. So we do the andrology testing, which is sperm analysis, as well as the embryology. And this was at the request of the reproductive people who said, we need to look at that. Even though it's not part of the government regulations, it's still important for women and reproductive success that it's done correctly.
Yeah, Ms. Driscoll,
And if I could add to that, in addition to those areas, we also look at the endocrinology, which is the hormone testing and the cryopreservation. So we have expertise in all those areas, and all of it is very important for successful pregnancies.
Yeah, great. So when we talk about the embryology part of the fertility clinic, what is the main goal of us accrediting that part of the entire operation of a fertility clinic? Why is that especially important?
Well, that's where the rubber meets the road. When we take the sperm and the egg, we collect them, we have to preserve them well, then they have to fertilize the egg and then preserve it for future use. And that's a very complicated process. And we can look at the steps, at each step that's being done and make sure it's being done correctly.
Great.
And that's the value we bring to the reproductive laboratories.
Great, great. So, once again, Dr. Scanlon, what are some things people can do to make sure that they're making the right decisions to engage with the right fertility clinic?
I think this is a key thing. There's a lot of people who need advice on this. And the first place I would say is start with your referring gynecologist. Trust your doctor. They'll know who's doing the job well and who perhaps not as good. So that would be my first state. I would say that if a fertility clinic is accredited, while it's not required, that would be something to take into consideration. There are also statistics that are available from the federal government on the success rate of the laboratory. So I'd look at all those things and maybe not spend too much time with Dr. Google.
Yes, good point. Ms. Driscoll, you want to add anything to that?
Just our work with the ASRM and SART, as Dr. Scanlon mentioned, is really key here because they help us keep our requirements up to date. We publish updates to our requirements every year, and the experts in the field are very involved in emerging technologies so that we have the requirements exactly for what they need to be today. This is not a stale science that doesn't change. It progresses rapidly. So we are set up to move at that pace with the world experts.
Great. So we now have a question from our audience, and we've already touched on this, but maybe here's a chance to sort of emphasize some key points. What are the benefits of accreditation for fertility clinics and to the patients that are being treated and cared for in these clinics?
Everybody has opportunities for improvement, and to get an outside set of eyes coming into your clinic and showing how things might be done better ends up with a higher success rate, and that is a direct benefit to the patient.
Ms. Driscoll?
Just to add some of the basic laboratory requirements for positive patient identification. You can't be too careful with that kind of thing in reproductive laboratories, just like in a medical lab. So we've got that expertise, and using technology, we can also help ensure that all of that labeling and identification is 100% perfect.
Yeah, great. So not a requirement to be a CAP accredited fertility laboratory, but certainly some benefits for patients who seek care in those clinics. So it looks like our time is up. I want to thank you both for being here and for all of our guests that have joined us today. If you're interested in talking with any of our panelists, please contact our media relations staff. Their contact information will be on the closing slide. Before we go, on behalf of the College of American Pathologists, we would like to urge everyone who is eligible to please get the new COVID vaccine. We hope you've been enlightened and we've provided some insight into exactly what pathologists do and their extensive reach across all of medicine. A recording of this media briefing will be available shortly at cap.newsroom.org. On behalf of the College of American Pathologists and our members, I want to thank you all for joining us today.